Good morning. Good morning, everybody. I'm Denise Smith. I'm the program manager for the Blueprint in the St. Albans HSA. I want to welcome everybody to the 2022 Learning Collaborative. I also want to welcome Darla and Heather from Bankrow, who are helping with sign language interpretation. I think everybody knows that these sessions are being recorded. They are living on the Northwestern Medical Center website under our community resources under Learning Collaborative. So these all of our learning collaboratives that we're doing are there, recordings of them are there in case you or colleagues of yours are interested in watching them. So today we're here to talk about death by overdose and preventing death by overdose, focusing on harm reduction and low barrier access. I'm just going to welcome everybody to this learning collaborative. We have a lot of great representation from law enforcement, education, government, healthcare with us today. I really want to thank everybody for coming as we embark on this collective learning collaborative. Also, thank you to all the presenters who are with us today. It's been a dedicated, tremendous amount of time by both the presenters and the organizers and the planning committee. And everybody working together to share their expertise and perspectives. Next slide. So what is a learning collaborative? So some of you were able to attend our last session in February and are probably recognize this slide. The learning collaboratives combine learning, social connectedness to provide both peer-to-peer and expert-to-peer learning. Through learning communities, peer organizations come together to focus on a problem, explore that challenge, and co-create solutions. Because this process happens in community, all of our successes are shared, and each site can adapt insights to their context. Next slide. This is really a Wordle or word cloud. Wordle, that's my new favorite pastime. A word cloud that came out of our first learning collaborative that we hosted to wrap up our chronic pain learning collaborative. It was from anyways, okay, so this is the word cloud that came out of that, and really the word collaboration, progress, and this is what people hoped for in their work in 2022. Next slide. These are the learning collaboratives that we're offering right now. We just hosted the one in February on preventing death by suicide. Today, we're focusing on preventing death by overdose. The final two on April 29th and May 20th, we're going to combine these two into more focusing on what we can do as a community, both in links between prevention and treatment, as well as building trauma-informed community from practice to policy. So we hope that you'll continue to join us beyond today's session. And just finally, a big shout out to the committee of people who have been participating in designing this learning collaborative, as well as Jennifer Nauer, our facilitator. We've had a really, really amazing opportunity to have many people add their insight and expertise into the design of this learning collaborative for our community, and are just very grateful for everybody who's been participating in that. So I am now going to turn it over to Chris Smith, and I see him, he just popped up on the screen. Good morning, Chris. I'm stumbling over my words a little bit this morning. I have not had enough coffee, but thank you for coming, and thanks for all your work. Chris, I'm going to turn it over to you for you to introduce yourself.
Yeah, thanks, Denise, and welcome everybody, and thanks for taking some time out of your busy schedule to join us for our second learning collaborative. Today, we're going to further develop and focus on our work to better understand how substance use disorder, and specifically opiate use disorder, contribute to risk of harm to self and death for some of our most marginalized and vulnerable people in our community. Our speakers and panelists are going to encourage you to think about how historic systems and practices of healthcare, criminal justice, and social supports impact these folks, and what we can do collectively or individually about this. Today, we're going to hear from several different roles and voices, advocates who can speak to philosophical approaches, policy leaders, and local providers who are boots on the ground engaged in facilitating this work. It's a really exciting and dynamic agenda. There's a bit of a break in the middle. Jen's going to go through in a moment some of the what to expect, and we're just really happy to have you here today. Thanks, everybody.
Good morning, everyone. So I'll pull up my screen so you can see at least the timing of the day. And Chris, to your point, there's a number of speakers, and I'll let you introduce them as they come up on the agenda. But hopefully what I'm hoping you take away from seeing this, everyone, is that there are a lot of different activities, different presentations, opportunities for question and answer, small groups, and of course, a little bit of interactive polling. So welcome to the Zoom space. A couple of tips before we start. I want to make sure that, in a big room, we would have name tags, and we don't have that in Zoom, but we are labeled. If you go to your participant tab or hover your mouse over your picture or your video, you can rename yourself, please, with your name and your organization and your pronouns if you wish. I will be spotlighting various speakers and presenters as we go, but in Zoom, you have lots of opportunities and chances to change your screen if you wish. All those options are in the upper right-hand corner of your screen, so you can change your view if you want. Sections of this meeting will be recorded and made available, as Denise was saying, for folks on the website. And I just want you to know, activities in this large room, when we're all together, will be recorded. Breakout rooms will not be recorded. And if you have technical questions, please address them to me in the chat, and I will go ahead and answer those as soon as I can. Chris, have I left anything out? So far, so good?
No, I don't think so, yeah.
So I'm going to step back and have you introduce our first speaker.
Terrific. So we're so happy to have Mike Selleck join us for the first portion of our presentation today. Mike is the Associate Director of Capacity Building at the National Harm Reduction Coalition. Mike's been a community organizer and advocate for human rights, focusing on police accountability, equality, drug use, sex work, homelessness, HIV, and hepatitis C for more than a decade. Prior to joining the organization 6 years ago, he worked at New York City's harm reduction programs, first with a focus on public policy and peer training, and then as the Director of Services at the South Bronx Syringe Service Program. Mike earned his Master's of Social Work with a concentration in public policy from Columbia University. Welcome, Mike.
Thanks, Chris. And I'm going to pull up some slides really fast and then just check to make sure that they actually look the way they're supposed to.
Right now, we see all of your slides.
All right,
Mike.
so now you should see big slides only. Yes?
Perfect.
Perfect. All right, so I was going to introduce myself, but I forgot that I gave Christopher a bio, so he kind of covered it all. I've been doing harm reduction work paid for about 10 years. I was a homeless organizer and a public housing and welfare organizer in New York City before that. Me and my family moved to Burlington, Vermont about 2 years ago. So all of my service experience is based in New York City, but I'm very excited to be invited here today because I would love to do more services that Harm Reduction Coalition provides here in Vermont. So my email address is right there, selleck@harmreduction.org. You can email me if you're looking for any free trainings. We have a large contract from the CDC, so I can offer these kinds of trainings to people. Today's going to be I have about an hour of time, so I'm going to be pretty quick. There's an activity, but this is the kind of trainings we do. Usually they're longer, so this is kind of just a little taste of the kind of work that we're doing. So with that, I guess I'll just keep going. So if you've never heard of National Harm Reduction Coalition before, here's our North Star statement. We create spaces for dialogue and action that heal the harms caused by racialized drug policies. We do policy and advocacy work, which is personally one of my passions. I was a big part of getting the supervised consumption spaces into New York City, making a New York State Hep C elimination plan, getting the naloxone standing order into New York so that people like myself, who's not a doctor, can give out naloxone. We have national and regional conferences. We do our national conference every other year in October. We were supposed to be in Puerto Rico in October 2020. For obvious reasons, that didn't happen, but we are having our conference this year in October of 2022 in Puerto Rico. The you go to our website and check out the conference tab, we are currently accepting scholarships right now. I think that only lasts like 2 more weeks. Abstracts go to April 15th. One thing I love about our conference is we don't go around saying, would you please speak at our conference? A lot of conferences kind of get the same every year because they do that. Ours is completely abstract driven, and our abstracts are not, you don't need to provide tons of data. We do accept researchers, but that's what this conference is about. If you're running a program, if you're an outreach worker and you think you have something to say, please submit an abstract, 1 paragraph about what you do. The way we review these is we take all the names and organization stuff off of it, and then everyone on staff reviews like 100 abstracts based purely on what was written there. So anybody could speak at our conference, and it gets you a discounted rate to get in. So check out our website if you'd like to know more about our conference. We do trainings and technical assistance. That's kind of what we're here today. We do overdose prevention work. And if you check out our website, harmreduction.org, we have tons of resources and publications. We've been around for 25 years and we've put out a lot of materials over that time. So if you can, please put your pronouns to your name. I realize you might not be able to see mine because I put my organizational affiliation, but I use he, him pronouns. Please mute your mic unless you're speaking. Please use the raise hand function if you would like to speak. You can find that by going down to the bottom of your screen and use the reaction button. Once you raise your hand, it does not automatically go back down. So when you're done talking, or if you change your mind, hit the raise hand button again so that you don't just have your hand up for the rest of the training. We're going to use something called the mentee meter that I'm new to, but Jen will be able to help us through it. And also you can use the hand clap emojis, anything else if you have, if you want to react and show us how you're feeling. And tech issues happen. We've been using Zoom a whole lot for the last 2 years, and as a national organization, we've been using Zoom for 3 or 4 years before that. But if something goes wrong, we're going to try to fix it as fast as possible. Okay, moving on. So here's a quick list of some terms we use. The thing that I really want you to take away from this is people first language. There's nothing universal about people who use drugs. Everyone has their own individual experience. They're all people before their drug use. The only thing you can say for it's 100% of people who use drugs is that they all use drugs, or we all use drugs. So we have people who inject drugs, people who use drugs. You see the PWID. Sometimes we see people at conferences just calling this PWID or using the acronym. If you don't say the word people first, it's not people first language. So when you might see these acronyms in the slides, but I will always refer to it as a person who injects drugs. Another one I want to make sure I cover is hepatitis C virus, or HCV. People often just call it Hep C. I often call it HCV. It might be on a slide that way. I want to make sure you know what I'm talking about. If it was the Hep A virus, it'd be Hep AV, Hep B virus, Hep BV. They're all 3 different viruses, and they can all affect your liver at one time. Being from New York, all of our regulations say syringe exchange program, so SEP. I prefer to use SSP as syringe services programs, basically because you shouldn't be exchanging necessarily. We don't need to do a 1-for-1. That's bad policy. It doesn't get people what we need. We should be on an access basis. If you need syringes, we should give you what you need. When people come into the programs I used to run, if they said that, we'd ask them how many times a day they inject, and if they said 5 and then they wanted 5 syringes, we're like, are you coming back later today? Like, maybe you should take enough for a week. What happens if it snows out and you can't make it back? So what is harm reduction? We have 2 different ways that we like to define it. With the capital HR is a movement based in a political liberatory framework that shifts power and resources to people vulnerable to structural violence. In the US, we think of this as a radical movement. Then there's a lowercase harm reduction. This is referring to the interventions and the practices. To me, harm reduction is about building trust and providing respect for people who maybe often haven't gotten that. They've probably been kicked out of a lot of programs before they end up at your door, and they're often not treated respectfully. This does mean that we have our typical classic interventions like giving out needles to people. However, if you give out a needle to a person and then you're highly stigmatizing, you're telling them, I hope you OD, something along those lines, you're not practicing harm reduction. And if you are working in a setting that is not able to give out needles, but you're treating people with respect, giving them all the information education they need to make their own choices. I don't say that in harm reduction we save lives. Some people do. I say that we provide the education, the physical materials like syringes, crack pipes, or whatever they need, but they're going to save their own life because of the information we give them. People are making their own choices. We can't force anybody to do anything. That makes people less likely to engage with the work we do. So what do we do overall? What are the benefits? We're challenging stigma and discrimination. And really importantly, we're increasing trust with clients. We're going to keep people engaged because we have stuff that they need. We're treating them respectfully. This is why giving out needles, although it is a great public health thing, it prevents HIV, hepatitis C, keeps people from getting endocarditis, soft tissue infections. It's also a way to make somebody trust you. Here's a needle, tell somebody, this is a place I can talk about my drug use. It doesn't always happen on the first day. Fairly often, I'll give somebody a needle and they'll say, oh, it's for my grandma, she's diabetic. And I'll say, okay, well, if your grandma wants some Narcan too, we have that as well. It might take a month of someone getting needles for their grandma before they're willing to actually talk about their drug use. But it's just a way that we can build trust with people and show them that this is a conversation we can have about anything. And we, of course, improve public health of the individuals and the community-wide. Get needles off the street and keep people safe. I had to leave this slide, so I'm just going to keep it going for the sake of time. So, I said, it's a set of practical strategies to reduce negative consequences of drug use and sexual risk. This is not hinged on abstinence. It's an important part of our spectrum. So people say abstinence isn't harm reduction. That's not true. Abstinence is the best way to reduce all of your harm from drugs. If you don't use drugs, you won't be harmed by drugs. That being said, that's not necessarily my goal. My goal when working with a person who uses drugs is to make them healthier, safer, and to support them to do whatever goals they have. My number one goal is that people don't die. And that's why our programs are low threshold, and that's why abstinence isn't the thing that we're pushing on people. If people want to stop using, that's great. But if people are coerced into stop using, their tolerance will go down. If they go back to using, they'll be very likely to overdose. So we incorporate a large spectrum of strategies from safer use technique, managed use, and including as abstinence. We meet people where they're at, but we don't leave them there. I think people in recovery, if they're coming in and making healthy choices about their life, if they're using syringes that are new and they're getting them from the program and staying connected to medical care, that's why it's so easy to use a strength-based perspective while working people at a syringe exchange program, because they could always be somewhere else, and instead they've come to talk to you about what's going on in their lives and to get tools to keep themselves safe. So harm reduction does not minimize or ignore the harms associated with illicit drug use and sexual activity. I want to be clear about that we know drugs can be harmful, but we also know that the war on drugs is the reason drugs are so harmful. Because we don't know what's in our drug supply, it's very likely people can overdose because one bag of drugs may get you high, or may not even get you high. You may still be in withdrawal. The next bag of drugs may be enough to make you overdose because it's completely inconsistent. We use evidence-based interventions to reduce the negative consequences of these behaviors, such as syringe access, naloxone, condoms, PrEP. And what we're doing is we're not judging a person for their drug use. We're addressing them as a whole person. In many situations, drug use is a rational response to a sick society. People aren't necessarily homeless and out of work because they use drugs. Maybe they're using drugs because they're out of work and homeless. And we're looking to get any positive change from people, but that means any positive change. If somebody's coming in and using new needles, returning them the way they're supposed to, getting tested for Hep C, this is something that we want to recognize as positivity instead of just pushing, and people already feel pretty bad about themselves. That makes them go back to drug use. We want people to feel like they're a strong person who's accomplished something, even just by showing up every time you're here. So harm reduction is a holistic approach to high-risk behaviors. We want programs to be low threshold, meaning there's very low barrier to entry. If you have to fill out a very complicated biopsychosocial, if you have to have health insurance, all these things can make it hard for people to engage. And we want people to come in. We want to go out and get people and then get them to come in. We want it to be convenient. One of my best friends ended up with endocarditis because they got rid of the program outside of her house and moved about 1.5 miles away, and she was less likely to go to it. The more convenient, the better. We need to be in the place where people use drugs. That way we can meet them where they're at and they can get what they need. And we want providers to be positive, honest, and productive, pragmatic, client-centered, and without bias. So that's just a little bit about what we think harm reduction is and isn't. I'll give you a brief history of what harm reduction is and where it came from. So in the 1970s is really where harm reduction was being pioneered. People who use drugs in the Netherlands formed junkie unions to demand fair drug policies. This was largely in a reaction to hepatitis B, because 1970s, we didn't have HIV or Hep C yet. But because of this, there never really was a huge outbreak of HIV in the Netherlands. They've had supervised consumption spaces for decades. They've had legalized syringe access. All of this functions to mean there's not very many needles on the street. People aren't injecting in public. I went to visit a drug consumption room when I was in the Netherlands a few years ago, and I was trying to talk to one of the people using the service, and he just couldn't believe that in the US, people have their syringes taken from them so that people are afraid to bring them back because if they get stopped and have them confiscated, they get in trouble. They couldn't believe that there was nowhere for people to inject safely. And he's like, so people are just using it in the parks, I'm guessing? I was like, yeah, he's like, that's terrible. I'm such a shame that that's happening. But the US has exported our war on drugs to make these kinds of harm reduction policies less common. As far as in the US, people who use drugs in the US began to provide syringe exchange in response to the HIV crisis. Edith Springer, who is a social worker and trainer from New York, visited the UK and Netherlands and returned to promote harm reduction in the US. She was a social worker at New York Harm Reduction Educators, which was my first paid job in harm reduction 10 years ago. And she was one of the early trainers at our organization, Harm Reduction Coalition. And she learned from what she saw overseas and brought it back here and taught a lot of people about how to do this work, because most of what we're doing in the US is lagging decades behind Europe and Canada. And a lot of our more innovative, best ideas come from talking to our friends overseas or up north. In 1988, the US got its first above ground syringe exchange programs. There was one in Tacoma, Washington, and there's one through the New York City Department of Health and Mental Hygiene. Unfortunately, that one was closed down when the next mayoral administration came in. And this is when activists from ACT UP, AIDS Coalition to Unleash Power, set up groups to go out and do syringe access programming. In New York, they got arrested strategically and had a judge declare a public health emergency so that syringe exchange programs could be regulated. So in New York, they were legalized around 1992, similar in California. So in 1993, we were able to see, we started the Harm Reduction Working Group, which is the people who, from the East Coast, West Coast, and Chicago, who had already had programs up for a couple of years and wanted to see this work spread across the country. So the working group wrote the harm reduction principles we're going to be reviewing for most of the rest of this presentation. And the Harm Reduction Working Group ended up turning into the National Harm Reduction Coalition. So 25 years ago, that's about when we started, and it really all came from this. So that's the history I'm going to provide for today on this. So now I'm going to talk to you about the principles of harm reduction. As I said earlier, harm reduction is the set of public health interventions, but it's really, most importantly, it's the principles. Ideally, you can have both, but if you're having a program that doesn't respect these 6 principles, you're not really running a harm reduction program, or more importantly, you're not using a harm reduction approach. These principles were created by the Harm Reduction Working Group 25 years ago. If you go to our website, you can see the full details of all the principles, and there are actually 8. For the sake of this presentation, we've shortened the numbers and the language has been changed. But I highly recommend going to check out the original language. I'm impressed every time I reread it that 25 years later, it's still an intersectional, justice-focused set of principles that could totally be written in the language of 2022, I think, which is impressive because 1990s were a very different time in how we use language. So go through all of them quickly. It's the health and dignity, participant-centered services, participant involvement, participant autonomy, sociocultural factors, pragmatism, and realism. I highly recommend trying, while I'm reading through these, to identify the difference between these 3 in the middle here. You can see my mouse, I hope. Participant-centered services, participant involvement, and participant autonomy. They all sound very similar when you say it that way, but there is distinct differences between all 3. So focusing on health and dignity, this establishes the quality of individual and community life and well-being as the criteria for successful interventions and policies. So what we're trying to do is give people a chance to protect their health. We're trying to improve the community life by helping to help people not inject in public, helping to make people learn how to inject more safely, providing syringe cleanups in the neighborhood, having people bring syringes back to us, those kinds of things. And this is the criteria we should be using for successful interventions, less so than whether or not they hit all of our contracts or whatever. We're trying to use the money that we get from funding to support the work that needs to be done instead of trying to fit into whatever box is necessary to charge Medicaid or to deal with some contracts that want you to do work in a specific way. It calls for participant-centered services, means we call for non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them reducing attendant harm. This is really important. We're not trying to recreate the carceral system within harm reduction's walls. People who use drugs are full of self-stigma. They are facing stigma every time they go out, whether they go to the pharmacy. Doctors have treated them poorly throughout their lives. They've probably been kicked out of a treatment program at some point, maybe kicked out of their parents' houses. All this judgment and stuff is working towards coercing people into change. When you coerce somebody into change, it doesn't work for long-lasting change most of the time. Most people will age out of drug use or will choose to look for other supports to stop using drugs. The best way to get us towards that is have somebody feel good about their life. People who use drugs generally care about their health. And a lot of people don't even want to be using drugs anymore. They just need to use them in order to feel healthy and not sick. And you can't really be judging people for that and expect them to then trust us and listen to the advice that we're going to give afterwards. So participant involvement ensures participants and communities impacted have a real voice in the creation of programs and policies designed to serve them. This is like having a community advisory board. We may be experts in the field, know all the research, but if the participants have no say in how the programs are going to be run, they're going to feel like they don't have any voice in here, and they're going to feel like they're being forced into things. The best way to get a program that works well and makes people get what they need is to ask the people who come to get services from you, what do you need? What would you like these services to look through? This could be done on a macro level at your organization, like a community advisory board or something along those lines, but it can also be done on a more micro level. If you're having a one-on-one conversation with a client or a participant, whichever term you use at your organization, asking them what they need, having them define their goals, having them help figure out what their quote unquote treatment plan will be is the best way to make sure your programs are like tailored to people's actual real needs. So participant autonomy affirms participants themselves as the primary agents of change and seeks to empower participants to share information and support each other in strategies which meet their actual conditions of harm. So autonomy means, independence, ability to make their own choices. We can't really empower someone. That would mean I have all the power and somehow I'm shoving it into you. What we can do is create conditions for empowerment. If I teach you about how to prevent hepatitis C, if I teach you that it's a curable disease, get you tested, and you don't have it, now you know how to make sure you don't get it. That means you have the knowledge and I'm giving you the tools like Clean Works so that you are able to do that. That makes you an empowered human being who can take care of yourself. Like I said earlier, I'm not saving your life by giving you a needle. I'm giving you the tools and information for you to save your own life. I'm just here to support you through it and make sure you know what the best way to do that is. So going back to these 3 in a row, so participant-centered means we're giving people services that are not judgmental or coercive, and they're what actually is focused on their needs, but it might not be what they have chosen necessarily. That's why the next one is participant involvement. This means the participants have a real voice in creation of programs. They get to design their own treatment plan, even if it's maybe not the most evidence-based one. We're not going to tell someone, don't go to detox, it'll make you overdose and die if you go back in using. We're going to support them if that's what their desire is, even though it might have less good evidence-based than working with methadone or buprenorphine, which is the gold standard for opioid use disorder and the only thing that cuts the death rate in half. We'll give people those choices, but they're empowered to make, we'll give those people those information education, but people are empowered to make their own choices at this point. And then participant autonomy recognizes that what I just said, they have the power to make the changes. We can't force them to do anything. They are the ones who make change. So there are subtle differences between all 3 of these, and we can talk more about that if people have questions later. This is my personal favorite one. I'm going to ask you what your favorite one is later, but sociocultural factors. This says recognizes that the various social inequalities affect both people's vulnerability to and capacity for effectively dealing with potential harm. And this is recognizing that people of different races, people of different genders, people who are lower socioeconomic standards, who are unhoused, are more vulnerable to harm from drugs and have less capacity for dealing with that harm. So that doesn't mean I think Black people are more likely to have drug problems or that poor people are more likely to have drug problems. It's recognizing the reality of the world we live in. Drug harms are not going to be prevented forever just because you're rich. Philip Seymour Hoffman, very well-known, famous actor, had tons of money. He did overdose and die. However, he probably was never arrested for his drug use. Why? Well, he probably could get some dealer to come to his house when he sends him a cell phone message, or maybe even got drugs from a doctor or something. He probably was never arrested for shooting up in a park because he was able to do it at his house. He had access to good lighting, medical care if he missed the shot or something. Take that same exact experience but put them as a transgender, like Black sex workers injecting in the park, they have multiple vulnerabilities here. And the cops might come and catch them injecting, so they're probably going to be rushing the shot. That might make them more likely to miss a dose. Instead of injecting slowly, which makes it less likely to overdose, they might be trying to do it as fast as possible, get out of there. They may be poking themselves full of holes because it's hard to see because they're in the dark in a park or in a bathroom or something. So that's what we're talking about here, is like recognizing that just because something might work for some person, what doesn't mean it will work for somebody else, and recognizing that not everybody has the same capacity to deal with drug-related harm. Because if you're living out of your backpack and worried about police harassment, you might not be willing to take 30 syringes that you need. You might say, I'm just going to keep reusing this one because I know I can hide it better. And being pragmatic and realistic. This is also, I think, a very important one. We're not attempting to minimize or ignore the real and tragic harm and danger associated with illicit drug use or other behaviors. I also think it's important to be pragmatic and realistic when you're giving people suggestions and advice. If we know somebody is homeless, maybe we shouldn't be trying to give them like 100 syringes to take if they feel like that's not safe. Whereas if somebody's housed, that may be something they can do. Telling somebody to never use alone, but recognizing that they have nobody they're able to share their drug use with may not be pragmatic and realistic for them. So maybe you should talk to them about the Never Use Alone hotline, or trying to find another place and some people from the program where they can use drugs together. So make sure that like anything you're suggesting is realistic for what that participant's actual lived experience is at that moment in time. All right, so we're going to use the mentee meter. Jennifer's going to help me with this. And what I'm asking here is, which one of these resonates with you? We're going to start with that question. So which one of these 6 principles resonates with you?
Yeah, and so this is a little bit of an activity, crew. In the chat, I'll put a link to a Mentimeter survey. If you've been in these learning collaboratives before, this is a familiar exercise. If you haven't, it's somewhat new. So let me walk you through it. In a moment, there in the chat, you see a link. If you click on it, it will open up another browser on your screen with a question that you can answer. And for a moment, I'm going to go ahead and stop sharing your view, Mike, so that we can go ahead and see the responses as they come in. So you can see that 8 of you, at least 11 of you now, are finding the poll. When you click back to your Zoom screen, you'll be able to see those responses coming in. Do you have any observations to make, Mike, or trends that you tend to notice about which of these principles tends to resonate with people, or reactions people have to them?
Not necessarily. I think it changes a lot. And I've seen here that everybody is kind of across the board fairly equally. I guess it's not so surprising that a lot of people feel like health and dignity is the one that resonates with them the most, because I mean, at the end of the day, that is really important. Like, we're all working in public health to some degree, and being able to help people feel able to like get their health and treat them with dignity is like, there's a reason that one is the number one, right?
Mm. Would you like to go to the next question, Mike, and see what that brings up, and then pause for comments if
Great.
people have them?
So the next question is, can we clear out the things? The next question is, which is the hardest to implement in the place that you work? So to be clear about this one, I'm going to assume that everyone thinks these principles are amazing and life-changing, and that no one's like wants to say, I hate this one. What we're asking for is, you know, the realities are, if you're a parole officer, have to have some coercive conversations with people, and that's part of your job, but there are ways to kind of use the harm reduction approach to having that conversation. So just so people feel like it's okay to write something, I'm not going to be offended. It's not like I feel like you're attacking these principles or anything. It's, you know, some workplaces are lower thresholds, some workplaces have policies that are better for this work, and some of them are a little bit more challenging.
Well, as answers come in, you're recognizing that these principles are at play in lots of different systems and some systems support them more intuitively than others.
Yes,
So for
my
those
first
of you,
social work internship was at a mandated treatment place where a lot of my clients were on parole. And so, and we didn't have needles or anything like that to give out. We were like social work, like groups, a lot of abstinence-based stuff. So the way I tried to practice a harm reduction approach there is I had a client who came to me on a Friday and was talking about how excited he was to smoke crack all weekend. And I said to him, you know that they're drug testing you at parole on Monday, right? And he said, I know. And I said, and you know it takes like 2 or more days to get drugs out of your cocaine out of your system, right? And he goes, I know. I said, okay, so you have a plan for this? And he said, yes. And I said, okay. Now, I would say that's a harm reduction approach there. I made sure he knew the very likely potential risks of what he was planning to do. I made sure he knew that he may become reincarcerated. I told him what the drug testing timing would be. And then I assumed he had a plan. He did not go back to jail. So either he didn't smoke crack and what I said to him changed his mind, or he had a plan. Either way, although that could have been a much more coercive conversation, instead it was, here's the information, you're now educated and empowered to make your own decision about this. And even though that was not really a harm reduction setting, I feel like I was still able to use a harm reduction approach in that setting. The consequences of drug use are real, and some of them are politically, or most of them are politically imposed, but they're still like missing veins and overdose. And being clear about that, not fear mongering on it, and then letting the person make their choice, even if it's a coercive system, still their choice, and knowing the consequences that are there. So I'm seeing that people having participant involvement, participant autonomy, and the sociocultural factors are the ones that people are finding the hardest to implement. I'm not surprised by that, because participant involvement and participant autonomy are generally ones that are more systemic, and in situations that are less, where you have less freedom to treat people that way. Like if you don't have a community advisory board, how are you going to get participants involvement? And if you're in a setting where where people have to go through certain treatment goals, it's going to be hard to respect their autonomy. Sociocultural factors, I think people struggle with because it's just newer. I feel like you can understand and respect that in all places, but it's kind of like cultural humility. It just takes a different kind of work, and it just, it's not, I think I'll just leave it for that then. So at this point, I think everyone voted. Should we go to the next part? We're gonna break into small groups. Should I put the slide back up?
Sure.
Great.
Yep, and then when you're ready, I can help with the transition.
Great. So do you all see the full slide now? Yes. So what we're gonna do here is the same 2 questions. Which of these principles resonates with you? Which is the hardest to implement in the place that you work? We're gonna split people up, or Jennifer's gonna put people into small groups. You're gonna have about 20 minutes or so to discuss this, and then we're gonna come back together and do a quick debrief. So while you're talking, if maybe one person could think of one thing they wanna share from their conversations, and we'll talk about it in a little bit. So whenever you're ready, Jennifer, we'll put them into small groups.
Yeah, and just a little course correction, because our time is so tight, we won't have time for a comprehensive report out. So you can take the time to really explore this in your group, and then Mike will be able to volunteer a couple answers if you have observations. So in the chat box, there are the 3 very specific discussion prompts. In the interest of time, please only briefly introduce yourselves. You'll be in groups of 4 to 5. So share your name and organization, in a brief sentence, the principle that resonated the most for you, and then go ahead and start exploring that 3rd question. So Mike and our upcoming presenter and interpreters, you will be in the same room together, so you can take a little breather. Everyone else, the breakout rooms are opening now. You should get an invitation. And if you have a hard time finding that room, I'll help you get there. Hi. So those of you who just came in might not have been assigned to a room. I'm going to go ahead and put you in a room if that's okay.
Looking for everyone to get back in the room.
Melinda, were your ears ringing?
They were, but I just thought it's because I didn't drink enough coffee.
No, I was just talking about you.
Welcome back, everyone. So Mike, I think everyone has landed back in a larger room now, and I will stand by for when you're ready to take questions or comments.
Sure. If anybody has any comments right now, we have about 5 minutes probably, or I should just get to my conclusion. So if you take a couple statements, comments, thoughts about which of these resonated with you and why, what you think that would be the hardest to implement and why, if anybody would like to share. And remember, no one's being judged here. Hardest to implement does not mean that you don't think these are the coolest principles ever and they're life-changing ideas for everybody. Even if you don't think it, I won't be offended, but that's not what you're saying when you say something's hard to implement. So whoever would like to speak.
So what did you discover in small groups, crew? If you have a comment, you can raise your virtual hand, and that's either found on your Zoom toolbar under the participant tab, or if you hover your mouse over your thumbnail. Any discoveries in small groups that you want to share or ask about? So there's a comment in the chat, right, that we noticed that a need of mental health, and it's a fragment of a chat. So I think there's probably more to that thought, but Mike, you might be able to work with that. We notice a need of mental health. What does that make you think of?
I mean, there's definitely a lot of people who are using drugs have mental health diagnoses, either diagnosed or undiagnosed. There's a lot of self-medicating here. And that's, if it works for somebody, that's something that's useful for them. There are some pharmaceutical alternatives like crystal meth and Adderall are almost essentially the exact same chemicals, but crystal meth may be tainted and Adderall is fairly pure. So if people, we often go the wrong direction with this. I've known many people who were using crystal meth and now are trying to stop and then realize they have ADHD and are trying to get Adderall and being told no because of their past stimulant use. Can we just give Cassie the ability to unmute because they can't find the wave the hand?
Yes, I know. It's so funny. You know what I love about Zoom is the creativity when people can't find the raise hand. There's clapping, there's all kinds of other things. Kathy, you can unmute if you have a comment and we'll take it on air.
Oh, hi, thank you. The two other people I worked with, we talked about the need, actually it was Carol that brought it up, that the need for mental health. And I know because I'm interested in this subject because I have a nephew that's dealt with opiate issues for many, many years. And I read the Not Enough book. Are you familiar with that, Michael? Excellent book. A woman that was an alcoholic and she became a psychotherapist or psychoneurologist, understand the brain, how it works when you're an addict. And she talked a lot about how that things that are inherited, like alcoholism is inherited, but it's not so much the drinking part, it's the anxiety that when they take a substance that goes away. So that need to calm that. And also, trauma in the people's lives, even though they may get off the drugs, how do they deal with the trauma that they're trying to cover up with the drugs?
Definitely. I usually think of substance use as a coping mechanism that is often turned maladaptive for somebody. So anxiety, it's hard to know like whether this is intergenerational because if you grow up in a house where there's trauma and there's intergenerational trauma, is it that like your biology has made you like more susceptible to drug use problems, or is it that you grew up in a space where you were dealing with intergenerational mental health issues or intergenerational trauma? But either way, I think to me, those feels like a maladaptive coping mechanism, particularly because we find that the earlier you start in your life, the harder it is to exit. So if you started using drugs in your 30s, it tends to be easier to stop using them. But if you started when you're like 12, it's much harder. And to me, this kind of supports my theory that the coping mechanism thing is if you're supposed to be developing these coping mechanisms teenage years, college years. And if you didn't because you turned to drugs every single time to cope, it makes it really hard to come up with them later. And it may have been like a good adaptation for you. Maybe you were so depressed that it was either heroin or suicide. And I'm glad you picked heroin so that you could live long enough to get out of that situation. But at some point, it becomes the problem. The drugs are very rarely the problem. It's usually something else happening, but at some point they become a problem for people, and having no other coping mechanisms to fall back on is challenging. So at one of the programs I worked at, we very rarely talked about drugs except for how to use them safely. Our groups were like yoga groups and just like support groups and things that talked about how to have a healthier and happier life. We took people who lived in East Harlem in the Bronx once a week, and we would rent a car and drive them across the bridge to New Jersey so they could go hug trees and be in the woods. And we found these things were really spoke to the people and helped for them. And I am not a hug a tree kind of New Yorker, so I kind of didn't really buy into the whole thing, but like every one of our clients thought it was the best thing we did, and like it really meant something to them. So I was willing to accept that must be working for people. Anybody else
Melinda.
have anything to say?
Yeah, go ahead, Melinda.
Sure, I think I'll just echo, because our group also identified concerns with mental health and the intersection of, especially if individuals are on medications and we are trying to support them with their substance use disorders. So mental health was one that came up. In implementation, one thing that was noted was being part of a larger organization. The pros of that are outstanding as far as access to resources and partnership and whatnot. And it also can sometimes create a barrier when it comes to time-sensitive response. So that was one of the pieces highlighted. Another one was from Amy with probation and parole, mentioning how health and dignity was, you know, an identifier that she had seen as one of the most important. And also what happens with the implementation of supporting the people that she supports sometimes is when somebody is struggling so much with health and dignity, they may be more apathetic and less invested in their own health and wellness, that the provider, and in that case, the probation officer, is working much harder than the individual. And that can be kind of a challenge that they see, is how can we get this person to care as much about their future as